What's up, Ninja Nerds? In this video today, we're going to be talking about diuretics. Again, this is a part of our clinical medicine section. If you guys like this video, it makes sense, it helps you, please support us. You can do that a couple different ways. Hit the like button, comment down in the comment section, or subscribe. It goes a long way. Also, for really helping you guys to understand this topic, go down in the description box below. We have a link that goes to our website. On our website, we have amazing notes, illustrations, quizzes, and so much more that I think can really help you to learn about these topics. All right, without further ado, let's get into talking about diuretics. All right, my friends, so we're gonna start off talking about diuretics, particularly kind of in the physiology of them. So their location of where they exert their effect, some of the mechanism of action, and just kind of getting an overall concept of these. Because I think once we really get a good understanding of their mechanism of action, I think we're really gonna have a good understanding of their indications and then associated complications that can arise with these. All right, so we have a couple different types of diuretics, and they're gonna be carbonic anhydrase inhibitors, your loop diuretics, your thiazide diuretics, and your potassium sparing diuretics. We're gonna start off first with the carbonic anhydrase inhibitors. Now these are diuretics, and where they usually exert their effect is going to be on the proximal convoluted tubule. And their mechanism is actually quite interesting. Now, when we talk about this particular area right here, this is where they are kind of exerting their primary effect. Now, what I want to do is I want to take and kind of zoom in on this area here and see a little bit more about this. Now, when a patient usually has filtration, so they have filtering across their glomerulus, right? You're going to have here is the tubular cell. Here is the vascular system, right? Here's going to be the lumen of the tubular system. Coming down this way, you're going to have a lot of the things that get filtered across the glomerulus. But one of them is going to be sodium. Another one is going to be bicarbonate, and that's really, really important. We have these channels or proteins that are present on the apical membrane of the proximal tubular cells. And what they do is they allow for sodium to move into the cell, and they allow protons to be moving out of the cell into the tubular lumen. So this is going to be kind of an exchanger, if you will. Now, sodium will move down its concentration gradient. The way that it moves down its concentration gradient is there's a pump on the basolateral membrane. And what this does is this pumps sodium, wrong color here, it pumps sodium out of the cell and pumps potassium into the cell. So it'll pump the sodium out of the cell and it'll pump the potassium into the cell. And usually it's 3 sodium for every 2 potassium. So that's our sodium potassium ATPase. By pumping the sodium out of the cell, you reduce the concentration of sodium in the cell. So sodium, when it's coming down through the tubular system, will go from high to low concentration. And that'll allow for it to pump this proton out. Now, another solute that could be coming out from the glomerulus is bicarb. And bicarb loves to combine with the proton. And when it does, it makes a molecule called carbonic acid. There's an enzyme right here. You see this pink enzyme? This enzyme is called carbonic anhydrase. And carbonic anhydrase is basically going to take the carbonic acid and break it down into CO2 and water, right? So that's supposed to catalyze that step. Now, what happens is the CO2 is lipid soluble, so it easily moves across this cell membrane. When it moves across this cell membrane, the CO2 combines with water inside of the cell, and in the presence of this enzyme, carbonic anhydrase, gets converted back into carbonic acid. And then carbonic acid gets broken down into bicarb and into protons. Now you're kind of probably seeing something very interesting. This reaction is kind of occurring backwards. This proton can get pushed out. So it's a very common cycle. And this bicarb, we can actually reabsorb. And usually we reabsorb that while we push in chloride. Because again, you're having a negative ion leave, you want a negative ion to come in. Why the heck am I mentioning all of this? You're like, Zach, I just got to know how this drug works to block all this stuff. Let's introduce in these drugs. Carbonic anhydrase inhibitors, there's primarily one drug. And this drug is called acetazolamide. Now, what acetazolamide will do is it inhibits the carbonic anhydrase. So what I'm going to do is I'm going to inhibit this enzyme. If I inhibit this enzyme, I inhibit this pathway, and I inhibit this pathway. If I inhibit this pathway, I'll have less protons that are being made. I'll have less bicarb that's getting reabsorbed. If I have less protons that are here, I have less protons being excreted. I have less bicarb that's combining with the proton, so I have less carbonic acid. So what you're kind of seeing here is I'm not going to reabsorb bicarb. So there's going to be a decrease in bicarbonate reabsorption. And what happens is if I can't take the bicarb and combine it with the protons, I won't make carbonic acid. So where's this bicarb going to go? It's just going to go and get lost into the urine. And so what happens is you get, you see that? Big, good catch. Increased bicarb loss in the urine. And so that's one concept here. So I'm going to lose bicarb in the urine. You know another thing? If I can't secrete protons out, can I bring and reabsorb sodium in? No. And so guess what else happens? This transporter doesn't kind of work as well. If this transporter isn't working as well, guess what happens? You also will lose sodium. So I'm going to have an increase in sodium loss into the urine. The benefit of this is when you lose sodium, what generally has the capacity to follow along with it? Water. And so these patients can lose sodium and undergo diuresis, which means that they're going to get rid of sodium and water. But also they're going to lose bicarbonate into their urine. And so that increases the risk of them having a metabolic acidosis, because if they don't reabsorb bicarb, their bicarb in the bloodstream is going to go down. And that's going to cause the pH to go down. So that's the concept I want you guys to understand here, is this is how it'll really induce diuresis. So it's going to cause kind of a natriuresis, which is going to be a secretion or excretion of sodium and water, but it's also going to cause bicarbonate to be lost, which can lead to a metabolic acidosis. So that's going to be our carbonic anhydrase inhibitors. All right. What about loop diuretics? What do these do? These are actually really cool. So again, carbonic anhydrase inhibitors work at the proximal tubule. The loop diuretics focus right here. So this is their primary area of focus. It's the thick ascending limb of the loop of Henle. That is its primary area. So we actually say this is, again, the thick ascending limb of loop of Henle. That is a mouthful, but it's primarily going to work in the loop, right? Now, it's actually pretty cool how this thing works. What we're going to do is we're going to take this area and we're going to zoom in. This is our tubular cells. This is the vascular system. This is the lumen. We're going to assume that some of this fluid is moving past, right, over this area. It's going to be coming through that lumen at the thick ascending limb. Whenever it does, again, it's going to be containing things like sodium, right? It'll contain things like potassium, and it'll even contain chloride. Now, what's really interesting here is that there's these channels right here at that thick ascending limb. It's called a sodium-potassium 2-chloride cotransporter. It's a lot of words. But basically, what's supposed to happen here is that sodium will get reabsorbed, potassium will get reabsorbed, chloride will all get reabsorbed. And whenever it gets reabsorbed, it's supposed to get pushed out here into this medullary interstitium. That's the whole concept here. It's supposed to get pushed out here. So I'm going to represent all these like little black dots here. It's supposed to get concentrated out here. And when that does, it's supposed to pull water. So theoretically here, you should be pulling water out into this medullary interstitium. That's really the mechanism. It's via this countercurrent multiplier mechanism, right? So I should be pushing out the sodium and the chloride here, which pulls water out into the area where there's lots of sodium and chloride. Well, here's where loop diuretics say, hold my beer. They come in, and what they do is they block this channel. They block the sodium-potassium 2-chloride cotransporter. When you do that, You can't bring sodium into the cell. And you know, you're supposed to have a transporter here. It's a sodium potassium ATPase. It's supposed to pump sodium out here, right? At least 3 of them. And what's that called? That's the sodium potassium ATPase. And then it's supposed to pump 2 potassium ions into the cell. Well, if I don't have this coming in, so there's going to be less sodium coming into that cell, again, I'm not going to have this pump working as well, but it will be working and trying to, generate some type of movement, but there'll be less movement of sodium out, less movement of potassium in, less movement of potassium into the cell. So what ends up happening here is the potassium concentration inside the cell becomes a little bit lower, all right? Becomes a little bit lower. Now, why is that important? The reason why that's important is because potassium usually, in normal patients, it'll kind of leak out through these effector channels. So it'll kind of leak out. And normally, whenever I do that, when potassium leaks out, it creates kind of somewhat of a positive charge. It makes the inside of the lumen of this tubule somewhat positive. But I have less potassium coming out. If I have less potassium coming out here, it makes the charge more negative. So it causes a negative charge of the lumen. Now, the reason why that's important is there's these ions that are also supposed to be running down through this area, like calcium and magnesium. Now, calcium and magnesium, whenever there's lots of positive charges, they don't like to go kind of in that area. And what they do is they like to run in between the paracellular route. But if there's negative charges, they're not going to run between this paracellular route as much. And so because of that, they usually want to go right here and into the bloodstream. But if I have a negative charge, they're going to want to go where that is. And so because of that, it inhibits this particular process. So here's what I want you to think about. I inhibit sodium and chloride reabsorption. That means I don't have as much sodium and chloride getting pumped out here. That means I don't have as much water getting reabsorbed here. So what ends up happening here with this whole process, which is actually kind of cool, is I end up having a patient who has an increase in sodium loss, an increase in water loss. So I'm going to have an increase in sodium loss, and I'm going to have an increase in water loss. That's actually pretty cool, right? The other thing here is that when you look at the negative charge that I create in the lumen, that's going to make calcium and magnesium not be reabsorbed. And so I end up causing lots of calcium and magnesium loss. And the reason why this is important is because when we give a patient loop diuretics, this is what we're really aiming for to diurese them, is to get rid of the sodium and to get rid of water. That's the benefit. But these patients will experience other associated complications such as the calcium and the magnesium loss. We'll talk about this later. But whenever you have lots of sodium that's getting delivered to the distal tubules, that also can increase potassium loss and proton loss. And so these patients are also associated having hypokalemia and metabolic alkalosis, but we'll get to that a little bit later. All right? But the big thing to remember here is that loop diuretics primarily work by blocking the sodium potassium 2 chloride cotransporter, can't bring the sodium in, can't bring potassium in, can't bring chloride in. If I can't bring them in, I can't pump them out into the medulla, I can't reabsorb water. I lose the sodium and the water into the urine. That's the diuretic effect. But also, because less potassium is being pumped in and because less sodium is being pumped in, this potassium ATPase won't be working as efficiently. Less potassium will come in via the ATPase, less potassium will come into the cell via the cotransporter, less potassium will be in the cell. That means less potassium will leave the cell passively, less positive ions will come out here into the lumen, and the lumen will become somewhat more negatively charged. That will then prevent the calcium and magnesium from wanting to be reabsorbed passively and instead stick with the negative charges. And then they get peed out. That's the concept that I want you to remember for loop diuretics. But again, remembering the overall concept here is this is the diuretic effect. It's going to lead to that natriuresis. Whereas this can lead to hypomagnesemia, hypocalcemia, but if you lose lots of sodium as well, it can lead to hypokalemia, metabolic alkalosis. All right, we talked about our loop diuretics, but here's the thing I want you to remember. Carbonic anhydrase inhibitors are acetazolamide. Loop diuretics, what are some of these? This would be things like furosemide. This is going to be, I'd say, by far the most commonly utilized one. There's also going to be torsemide. And then the last one is going to be bumetanide. And these are going to be the most common loop diuretics. There is another one, it's called ethacrynic acid, but it's less commonly utilized because of its risk of ototoxicity. All right, these are our loop diuretics. Let's now move on to the next group of diuretics, which is our thiazides. With thiazide diuretics, these ones are interesting. And we talk about these, the location of where they work is where? Well, we're kind of going in order here. We've filtered some stuff off, right? Maybe some sodium, some bicarb, and we blocked that, right? So we blocked off here the sodium and the bicarb. Who did that? Do you guys remember? That was the carbonic anhydrase inhibitors. We also blocked off here sodium and chloride. And again, that was going to be potassium and chloride a little bit too, but primarily here in the thick ascending limb. That was loop diuretics. The last one is going to be your thiazide diuretics. These primarily work right here in the early parts of the distal convoluted tubule. That's its primary effect. And the primary location where we need to focus on is on the early distal convoluted tubule. Okay. Now, when we focus on this area, we've already are kind of thinking about fluid has made it past the proximal tubule. It's made it past the loop of Henle. And now the fluid has entered into this part of the distal convoluted tubule. What are we looking at? We're going to take, again, this part here and zoom in on it. Here's a tubular cell, here's the blood, here's the lumen, and things are running through. Well, there's going to be, again, sodium, and there's going to be chloride here. Just kind of similar to the loop diuretics. That's a sodium potassium 2-chloride cotransporter. This one's a sodium chloride cotransporter. What's supposed to happen here is that both of these are supposed to be reabsorbed here at the early distal tubule. And this is non-aldosterone regulated. In other words, aldosterone doesn't control this particular area. But sodium and chloride get reabsorbed. When sodium gets reabsorbed, what generally should happen is there's a pump over here. It's called a sodium potassium ATPase, and it should pump 3 sodium out, right? And it should pump 2 potassium in. We already kind of know this concept, that it's going to pump 3 sodium out, 2 potassium in. So again, what we're seeing here is that patients will have reabsorption of sodium, they'll have reabsorption of chloride, and that sodium should get reabsorbed out here. The other thing is that sodium. What happens is some of the sodium can actually run into the cell. It'll run down into the cell. And when it runs down into the cell, it can lead to the reabsorption of another molecule, or at least kind of moving from the cell here, and this is going to be calcium. So when sodium runs down into the cell, calcium will come out of the cell. Here's what's really interesting. If calcium is rushing out of this cell, if there is any calcium that's running by, calcium will look into the cell and say, ooh-wee, a lot of calcium's getting reabsorbed here. It's getting moving over. I better move in as well. And so that's a really important concept. Now here's where thiazide diuretics kind of come into play. Thiazide diuretics block this sodium chloride cotransporter. I will not bring the sodium and the chloride in. Less sodium will get pumped out here as well though, right? But here's the biggest thing. If I don't bring sodium into the cell, that's the biggest component here. If I don't bring sodium into the cell, I'm going to end up with a decreased concentration of sodium inside my cell. So this sodium potassium ATPase will still keep pumping sodium out and potassium in. But the biggest thing is that the sodium concentration is going to be low inside the cell if I block this transporter, because I'm not bringing as much in. So then what happens is sodium sees this and sodium rushes in more. So that's going to be the big thing, is that you're going to actually stimulate, this will stimulate increased sodium entry or influx. And then if you have a positive ion coming in, guess what you have to have going out? A positive ion. And so what this will do is this will stimulate an increase in calcium efflux. And if you have an increase in calcium efflux, guess what's also going to start influxing? Then you're going to have calcium influxing here as well. You're going to have an increase in calcium influx. Here's the concept. So watch this, ready? If you block this transporter, you don't bring as much sodium in. If I don't have as much sodium in the cell, the sodium concentration outside the cell in comparison to inside the cell, it's going to be higher out here than it is in here. Sodium will then rush in. If sodium rushes in, calcium has to rush out. That then makes the calcium concentration in here low. What's that going to do to the calcium out here in the tubular lumen? It's going to say, oh baby, I got to rush in. And then it's going to get spit back out. And so that's the concept, is we're going to increase calcium reabsorption. And by doing that, what you're going to see is the patient will develop an increase in calcium reabsorption in comparison to what we talked about with loop diuretics that cause calcium loss, because it won't allow the calcium to be reabsorbed paracellularly. This is going to actually lead to a lot of calcium reabsorption. And so that's a benefit. But if I block this channel here, what am I really doing? I'm actually leading to a lot of sodium loss. So I'm increasing my sodium loss. And again, it's a lot more sodium loss than there is water loss, but I will also lead to water loss. But funny enough, thiazide diuretics are going to cause more sodium loss than water loss. Because if you think about it, within the parts of the nephron, here you're going to have lots of water reabsorption. By the time you get water here to the distal tubule, there's not as much water that's remaining. And so you're not going to have as much water loss with utilizing a thiazide diuretic as you would with a loop diuretic. You're going to get way more water loss with that one. So you're going to get sodium loss and some water loss. And that's going to give you that diuretic effect. This is what's going to induce that diuretic effect. And it's going to be a true natriuresis effect. Now, the other concept is because we're not actually causing calcium loss, you're going to get increased calcium reabsorption. So these patients actually can have hypocalciuria. They don't dump a lot of calcium into their urine. The other big thing that we talked about is whenever you lose lots of sodium and deliver it to the distal tubule, you cause potassium loss and proton loss. And so these patients can develop hypokalemia and metabolic alkalosis. And so you're going to notice kind of a recurrent theme with these when we get into talking about some of the complications that can arise with the use of these. But basically, carbonic anhydrase lead to sodium bicarbonate loss. Loop diuretics cause a lot of sodium, but more water losses. And thiazide diuretics cause more sodium and water losses. One blocks at the proximal tubule, acetazolamide. One blocks at the thickest ending limb, the sodium potassium 2-chloride cotransporter, loop diuretics. And then one blocks at the sodium chloride cotransporters, thiazide diuretics. One causes loss of calcium to the urine, loop diuretics. One causes increased calcium reabsorption, thiazide diuretics. So what are some of the names of these thiazide diuretics? Because we should definitely know these, right? There's a couple of them. One we call hydrochlorothiazide. Another one is called chlorthalidone. Another one is called metolazone. So metolazone. And there's even chlorothiazide as well. So there's hydrochlorothiazide, there's chlorthalidone, and there's metolazone. There's even other ones like indapamide is another common one as well. But I'd say these are going to be the most commonly utilized ones that you would see in patients who are receiving thiazide diuretics. Now, we've talked about thiazides. We got to come to our last diuretic group here, which is our potassium-sparing diuretics. You're probably also wondering, Zach, isn't there osmotic diuretics? There is. SGLT2 inhibitors can also be considered osmotic diuretics. Again, because of the mechanism by which they work, causing a lot of glucose into the urine. And mannitol is also technically an osmotic diuretic. But I'm not including these into this lecture per se. All right, but do remember, yes, mannitol, as well as SGLT2 inhibitors can cause osmotic diuresis, which is more water loss. It's more of an aquauresis. But again, we'll talk more about SGLT2 inhibitors in CHF and talk about that in diabetes. And then mannitol, we'll talk about that more particularly and the utilization of intracranial pressure. All right, potassium-sparing diuretics. So within these, we've kind of hit a couple different areas. One, if we're blocking sodium bicarb loss, which one's this one? Just again, keep reminding yourself. This is acetazolamide, right? All right, so it'll cause metabolic acidosis and cause a diuretic effect with sodium and water loss. Here, if I block at the thick ascending limb of the loop of Henle, I block the sodium potassium 2-chloride cotransporter. And I lead to sodium loss, but more water loss, and then calcium and magnesium loss. And then here is your thiazide diuretics. They're blocking the sodium chloride cotransporter, leading to heavy sodium loss, some water loss, but you're conserving their calcium. The last one is here. It kind of like what we would say is the cortical collecting duct or the late distal tubule. This is going to be where the potassium-sparing diuretics work. So I would say that this is going to be the late distal convoluted tubule and the collecting duct, particularly like the cortical collecting duct. All right. So now, at this point, we think about this. You filtered. Things have moved through the proximal tubule, through the loop of Henle, through the distal tubule, and we're reaching it right here. We're going to zoom into this piece and look at how the things are flowing down. Now, at this point, we don't got a lot of sodium. We don't got a lot of potassium, a lot of water left over, but there is some of it, right? So what you'll notice here is that this area, there's these channels, and these are called your ENaC channels. So these are called your epithelial sodium channels. Now these ENaC channels are controlled a couple different ways. One is they can be controlled by aldosterone, and that's usually the biggest way, but we can also affect them with other drugs that just directly bind to this channel. What happens with these channels is that they're supposed to bring sodium into the cell. There's another channel also that's present here usually, and this one also is going to lead to potassium excretion. So there's going to be a potassium channel here. As in there's another one that leads to proton secretion. So there's one that leads to proton secretion, there's one that leads to potassium secretion. So here I want to actually name the drugs first because it's actually important because there's two categories. One is going to be your aldosterone antagonist. And this is going to be spironolactone or eplerenone is another one. All right. The other one is going to be your epithelial sodium channel blockers. And the most common one is going to be amiloride, and another one is going to be triamterene. But these are going to be two different types of mechanisms by which they work. The aldosterone antagonist, it's really important to remember this. Aldosterone, when it's present, does what? Let's say here I have a receptor, an intracellular receptor. Here's my intracellular receptor. Aldosterone is supposed to bind onto this and then basically leads to the expression of particular proteins. In other words, it expresses these ENaCs. So it opens up these little channels in the membrane there. If I give a drug like spironolactone or eplerenone, what I do is I block aldosterone. If I block aldosterone, I decrease the expression of these ENaC channels. And then by default here, I don't allow sodium to rush into this cell. If I give an ENaC blocker, I'm giving a drug that is directly blocking this channel. So you're getting it in two different ways. Aldosterone antagonist blocks aldosterone, leading to less ENaCs. The ENaC blockers just directly block the ENaC channel. They don't affect aldosterone. Either way though, less sodium is coming in. And that means that less sodium would be exchanged here to some degree, right? Because again, we know that you're going to have these sodium-potassium pumps that work here as well. So there would be some degree of less sodium reabsorption here. But here's the other thing. Aldosterone also really heavily involves potassium excretion. And so what you'll notice with this is that we also have these patients that we can, giving these drugs, inhibit potassium excretion. So we can give aldosterone antagonists, they block aldosterone. Aldosterone not only is increasing the expression of ENaC channels, but it also increases the expression of the potassium channels and the proton channels. But when you give ENaC blockers, it also by default leads to this same kind of process. And so what we see here is that these patients lose a lot of sodium and they don't excrete protons and they don't excrete potassium ions. So that's the overall effect here, is that you're going to lose sodium, right? So there's going to be an increase in sodium loss and an increase in water loss. So you're going to get somewhat of a diuretic effect here. But I would say it's not going to be as profound as you would see with the loop diuretics or the thiazide diuretics. But you're going to get a diuretic effect. Because you're not allowing for potassium to be excreted and protons to be excreted, these patients have decreased proton loss and decreased potassium loss. And the benefit of that is this is one of the only diuretics that doesn't lead to potassium loss. Loop diuretics lead to potassium loss. Carbonic anhydrase inhibitors lead to potassium loss. Thiazide diuretics lead to potassium loss. The reason why is because all of them lead to increased distal sodium delivery, which causes potassium to get yanked out of those cells in the collecting duct. Potassium-sparing diuretics are the only ones that don't cause potassium to be lost into the urine as much. And on top of that, it also doesn't cause, it's one of the few, besides the carbonic anhydrase inhibitors, that also decreases proton loss. And so this increases the risk of acidosis. Loop diuretics and thiazide diuretics increase the risk of metabolic alkalosis. So that's a big thing to remember as well. Now, we have an understanding of the potassium-sparing diuretics. What do? They block the ENaC channels, they block potassium excretion, and they block proton excretion. And this is the effects that they'll experience. Now that we know all of this, what I want to do is I want to go through each diuretic class and talk about what are the indications and what are the complications that you have to watch out for with utilizing these drugs. All right, so we're going to go through one by one and kind of a little bit recap the mechanism. But again, we're going to talk about primary indications of why would we utilize these drugs and then what kind of complications can run awry if we potentially don't use these in the correct way or we overuse them. It's really important to recognize that. So carbonic anhydrase inhibitors, when it comes to that diuretic effect, it's not, believe it or not, you would think, oh, it's working at the proximal tubule, it's blocking sodium reabsorption. That's where like 65% of water reabsorption occurs. It's going to cause a massive diuretic effect. It doesn't. So it's not a very powerful diuretic. But again, we do know that with this drug, since you are kind of like to a degree blocking that sodium and that bicarb reabsorption, so you're blocking that sodium and you're blocking that bicarb reabsorption, you're going to lead to some degree of sodium loss in the urine, which is going to be helpful in what particular indications? This is good in hypervolemia. But really it's an adjunct. It's an adjunct. So because we're blocking this, that sodium and that bicarb are going to be lost into the urine. So you're going to lose some of that sodium, right? So you're going to have an increased sodium loss. And if you lose some sodium, you'll also, along with that, you'll lose water, right? So you're going to have some degree of associated water loss. And because you're losing both of these, you're getting that diuretic effect. You can utilize this in hypervolemia. So in patients who have pulmonary edema, who have peripheral edema, who have jugular venous distension, weight gain, other kinds of diseases where they're hypervolemic. Problem is, it's not a sole use. It's an adjunct. So it's an adjunct. So in other words, it is a add-on therapy when they have alkalosis. So whenever a patient has really good alkalosis, a metabolic alkalosis, we can add this drug into the mix. So in other words, the best one for hypervolemia is loop diuretics, because it's going to get rid of a lot of water loss. It's going to get rid of a lot of water and a lot of sodium. So it's going to really have a good diuretic effect. Carbonic anhydrase inhibitors, they're good for hypervolemia, but they're usually an add-on therapy when the patient becomes super alkalotic, which is a complication of loop diuretic use. And so it's an adjunct, it's an add-on therapy. The other benefit of this drug is because it causes bicarb loss, it's a decent drug that we actually like to give to patients who have altitude sickness. So because you get rid of bicarb, you know what you do to the pH? So if you have a lot of bicarb loss, what you do is you make the pH of the blood, essentially you make the pH of the blood go up. So if you're getting rid of a lot of bicarb, if you're getting rid of a lot of bicarb, you're going to have less bicarb in the bloodstream. And so if you have less bicarb in the bloodstream, the pH will go down. So that will cause the pH to drop, and that'll create an acidosis. This is good. You know what situations this would be good for? This is good whenever a patient has, again, altitude sickness. All right. So whenever they have altitude sickness, this is good in altitude sickness. The reason why this is good in altitude sickness is when a patient's going up at high altitudes, they usually have less oxygen. And so when they have less oxygen, they breathe really fast, and they develop respiratory alkalosis. And so if you give them acetazolamide, it causes them to get rid of bicarb and makes them acidotic, and it fixes that particular issue. And so again, this is good in altitude sickness because it is good in a respiratory alkalosis. They get a respiratory alkalosis from this particular scenario, all right? So that's what I want you to think about in this particular situation, all right? So the diuretic effect can lead to utilizing it in patients who have hypervolemia as an adjunct, an add-on to loop diuretics, or you can give it in patients who have altitude sickness because you get rid of the bicarb, which causes their pH to go up, which counteracts altitude sickness due to respiratory alkalosis. Other associated effects, I don't want to get too crazy on these, but they can decrease aqueous humor production and decrease CSF production. So they can decrease aqueous humor production. And if you decrease aqueous humor production, this can decrease intraocular pressure, which is good in glaucoma. So this could be utilized in a patient who has underlying glaucoma. So that's one of the potential benefits to this drug is it can decrease intraocular pressure. It also can decrease CSF production. If I decrease CSF production, I have less CSF within my ventricular system. That could potentially reduce the intracranial pressure. This is good in idiopathic intracranial hypertension. And so that's also important. We give this in patients who don't have disease-occupying lesions that's causing their ICP to go up. We give it in idiopathic, where they just produce too much CSF. We counteract that by reducing their CSF production. And by doing that, we reduce their ICP, which reduce their intracranial hypertension. And so these are potential scenarios where it could be good in. All right. So this is when we would give carbonic anhydrase inhibitors, but the primary indication for renal-related things like diuretics is as an adjunct when a patient starts becoming alkalotic, because this gets rid of sodium and bicarb. So that's the benefit of this drug, is that you can use it in this particular scenario. Okay, the next thing is what could be potential complications? Well, we're utilizing the potential benefit of our carbonic anhydrase inhibitor as a true benefit in a patient who's undergoing a very intense diuresis. So what we know is that this is basically decreasing bicarb reabsorption. So I'm not going to be reabsorbing bicarb, all right? So less bicarb is going to get into my bloodstream. If I have less bicarb in my bloodstream, I'm going to develop a metabolic acidosis. And that is the potential complication. Now, it's again a benefit if a patient is having a metabolic alkalosis due to loop diuretic use. You can give them this to get rid of the actual bicarb and treat that issue. So it augments diuresis and then treats the complication. All right, that's carbonic anhydrase inhibitors. The next thing I want you guys to understand is loop diuretics. So with loop diuretics, the true proven benefit of this drug is, again, we're leading to less sodium and chloride reabsorption. If I have less sodium and chloride reabsorption, that means I have less solutes that are present here in the medulla. That means less water is going to get reabsorbed. What that essentially means is if I don't reabsorb water here and I don't reabsorb sodium here, then what ends up kind of after this point reaching it to, I'm going to have lots of sodium and lots of water that I just did not reabsorb. What happens here is that then some of this stuff gets lost into the urine. And I'm going to get a hefty amount of sodium and a hefty amount of water loss. And so the benefit of this is this is going to be very, very good in hypervolemia. This is going to be your frontline agent. This is your first line drug. So when I have a patient who's very, very hypervolemic, they look like the Michelin man essentially, right? They have pulmonary edema, peripheral edema, ascites, weight gain, they have jugular venous distension, etc. The whole mix. This is a first line drug that I want to give because of that effect. The other benefit of this drug is that when you give this drug, anytime you essentially, we're going to kind of put this here on the side, anytime you increase distal sodium delivery, this causes increased potassium excretion in the collecting duct. So then what happens is these patients, because you're delivering a lot of sodium here, that causes a lot of sodium essentially to rush in here, which causes a lot of potassium to be excreted out here. And these patients get an increase in potassium loss. And this means that you could utilize this in hyperkalemia. That's the benefit here, is that I really love to use this drug in a patient who has concomitant hypervolemia and hyperkalemia, because it causes sodium and water loss, but also causes distal sodium delivery. And that distal sodium delivery is what really hypes up sodium reabsorption and potassium excretion in the collecting duct. Now, we've talked about this in hypervolemia, we've talked about it in hyperkalemia, right? That's its indications. One of the big things is to understand the complications that can arise. Kind of going step by step. You know uric acid. Uric acid is supposed to be kind of excreted, especially at the proximal tubule. And what happens is, so are loop diuretics. Loop diuretics are actually supposed to be excreted at the proximal tubule. When you give a patient loop diuretics, it competes with the uric acid. And so generally loop diuretics, again, you want these to also have some degree of kind of excretion here. They compete with the uric acid. And essentially, they block the uric acid from being excreted. If you block uric acid from being excreted, what happens is you cause uric acid to build up in the bloodstream. So you cause increased uric acid in the serum. And the problem with that is you increase the risk of the patient developing something called gout, right? And so that's one of the potential downsides of this drug if utilized in very high amounts, is it does potentially, especially if a patient has hyperuricemia or they have a pre-existing history of gout, it can increase the risk of a gout event. The other thing here is because this patient, again, you're blocking sodium and chloride sodium chloride and potassium reabsorption here, right? So you're blocking sodium reabsorption, right? That means you're going to have less of this sodium pumped out here. If I have less of that sodium and chloride pumped out here, again, I know that I have less water being pumped out here, right? And so I'm going to retain a lot of sodium and water. And again, we already kind of hit this concept here in the sense that if you do that, you're going to be delivering more sodium and you're going to be delivering more water to the distal tubule. Now, one of the benefits of this is that it's going to induce diuresis. And so this patient can get a heavy amount of sodium loss and a heavy amount of water loss. The downside to this in a patient is if you do too much, if you over diurese the patient. In other words, you take off too much fluid, you can actually induce hypovolemia. So this comes with an increased risk of hypovolemia, right? And so you want to watch out for that. So watch out for a patient having an increase in the creatinine. Watch out for them having hypotension. Watch out for them now having dry mucous membranes. Watch out for them developing potentially hypernatremia, right? So all of these things are potential evidence of the patient becoming a little bit more hypovolemic because you over-diuresed them a little bit too much, all right? Other concept here is that, remember, whenever you were causing all of this activity where you were having less potassium coming in from this sodium potassium 2 chloride cotransporter, remember that left less potassium coming out. right? So again, we said that there was less sodium, less potassium, less chloride coming in, but then if there was less potassium in here, less potassium comes out. And if less potassium came out, what that did is that inhibited calcium and magnesium from being reabsorbed passively. And essentially what that ended up doing is that ended up causing calcium and magnesium to kind of get lost further down. So what ends up happening now is that this ends up inhibiting these guys from getting reabsorbed. And if you inhibit this reabsorption, that calcium and magnesium ends up getting dumped into the urine. And because of that, this patient now is at higher risk for hypocalcemia. So you're going to have increased magnesium loss, increased calcium loss. And so that puts the patient at high risk of hypocalcemia and hypomagnesemia. That's a really important complication. So watch out for hypocalcemia or hypomagnesemia. Keep an eye, every time you diurese a patient for hypervolemia or hyperkalemia, you keep a close eye on their volume status. You keep a very, very close eye on their electrolytes, especially the calcium and the magnesium. But the other concept here is that, again, anytime you deliver a lot of sodium to the distal tubule, you got a lot of sodium here, my friends. When you got a lot of sodium here, what happens? Sodium rushes in, and again, same thing here, it would rush down here as well. Sodium would rush in there as well. What would then come out? A positive ion. And the positive ions that are usually lost in this particular scenario is potassium and protons. So in the same particular scenario here, I would pump in sodium because I'm delivering a lot of it, and I would pump out protons, and I would pump out potassium. And when I pump out more of these puppies, what ends up happening is I end up getting a lot of potassium loss, and I'm getting a lot of proton loss. All right? The potassium loss is obviously one of the reasons why we want to use this drug, is because of the increased risk of using it for hyperkalemia. But if you give too much, you run the risk of hypokalemia. And if you over-diurese a patient, or you give a patient a loop diuretic and you get rid of too much protons, you have less protons that are present in your serum. If you have less protons present in your serum, what happens to the pH? You have an increased pH of your serum. And because of that, the patient can develop metabolic alkalosis. So this is kind of like tying together what I was talking about before. Whenever you deliver a lot of sodium to the distal tubule, you can cause potassium and proton losses, increasing the risk of hypokalemia and metabolic alkalosis. So the biggest things that you really want to be careful for anytime you put a patient on a loop diuretic is, I'm giving it because they're hypervolemic. I want to watch out, make sure I don't do too much of it and cause hypovolemia. I'm giving it for hyperkalemia. Make sure I don't cause too much hypokalemia. While I'm diuresing a patient, keep a close eye on their calcium and the magnesium, keep a close eye on their pH and make sure they're not becoming too alkalotic, and watch to see if they develop any worsening symptoms of gout. The other thing is, you can also see with these patients, they also have a very high risk. This is probably the biggest one for your exams, is they have a super high risk of ototoxicity. So there is an increased risk of ototoxicity. But I'd say that this is usually very, very high doses, and also more associated with ethacrynic acid. So you can see this with high doses or the utilization of ethacrynic acid. To kind of summarize here, the carbonic anhydrase inhibitors, give it to patients who have the need for diuresis because they have hypervolemia, but they also have a concomitant metabolic alkalosis, or altitude sickness, glaucoma, idiopathic intracranial hypertension. The primary adverse effect is metabolic acidosis because you're not reabsorbing bicarb. Loop diuretics, give this in patients who have hypervolemia because they cause a lot of sodium and water loss. Also give it in patients who have hyperkalemia because they deliver a lot of sodium to the distal tubule. Complications to watch out for is if you over-diurese them, you can cause hypovolemia. You can also decrease uric acid excretion, increase the risk of gout. You can also cause too much potassium loss and too much proton loss, where you cause hypokalemia and metabolic alkalosis, and you can cause hypocalcemia and hypomagnesemia. Last thing is, with high doses or ethichronic acid use, you increase the risk of ototoxicity. Okay, let's move on now to thiazide diuretics. All right, so thiazide diuretics is our next one. With this one, again, the big thing to remember is, again, it's blocking that sodium chloride co-transport in the early distal tubule. And again, it's causing sodium loss, more sodium actually than water loss, but it's conserving that calcium, right? And so when we kind of go back to that mechanism as a simplistic sake here, we're blocking sodium and chloride reabsorption, but we're increasing because of the mechanism. Remember, when we block the sodium chloride, we have less sodium here, more sodium comes in, more calcium goes out, pulls more calcium into the cell from the filtrate. So again, we're blocking sodium reabsorption here, and we're stimulating calcium reabsorption here. And so the concept here is that with this, you're going to be bringing a lot of sodium, and with that, water loss into the urine. And so you're going to get sodium loss, but more so sodium loss, and you're going to get some water loss. And because of that, you can see these patients with being disutilized and hypervolemia. But I'm going to again add on here, it is good in hypervolemia. There's no doubt about it. You can use this, but it's not your first line. It's usually an adjunct. So it's an add-on therapy. So as I said before, which we talked about over here, it's an add-on therapy, as we use with carbonic anhydrase inhibitors. When a patient has hypernatremia. And it's because one of the things that we start to notice is patients who we treat with loop diuretics, they are having a slightly higher risk of hypernatremia with frequent usage. And that's because you're kind of depleting their vascular system, activating their renin-angiotensin-aldosterone system, and they try to conserve sodium. And so they do get a little bit hypernatremic in those scenarios. And so when we do continue loop diuretics, they can start to become hypernatremic. That's a good time to add on thiazide diuretics because they cause a little bit more sodium loss than they do water loss. And so it kind of counteracts that effect. The other benefit, though, to this drug, and it's kind of a side effect of it, is that you stimulate calcium reabsorption. And why is that actually helpful? Because it decreases calcium loss in the urine. And the benefit of this is that if you decrease calcium loss in the urine, this is great in two particular scenarios. It's good in osteoporosis, because what you're going to do is you're actually going to help to maintain a good calcium level in the bloodstream, because you're going to actually maintain good calcium levels in the bloodstream. You can keep utilizing that from the osteoblasts. They keep depositing that in. But a better indication of this is that it's good in calcium stones. So calcium phosphate stones, calcium oxalate stones, it really helps to decrease the risk of those forming, because what you're doing essentially with this thing is you're decreasing the calciuria. And that calciuria is really the trigger, the solute that can lead to these kidney stones. And so the benefit of giving this drug could be utilized in patients with calcium phosphate, calcium oxalate stones, more particularly the calcium oxalate stones, but also can be given in osteoporosis, in patients who have osteoporosis plus hypertension. With that being said, this drug is weird. I don't know exactly how the mechanism is, but it works particularly and maybe stimulating some receptors on the smooth muscle. And when it stimulates the smooth muscle receptors, what we know is it causes this vessel to undergo vasodilation. So it undergoes vasodilation. If it causes vasodilation, what would that do to the diameter of the blood vessel? It would make it bigger, right? And so essentially, when you vasodilate, you decrease systemic vascular resistance. And what we know about that equation is that blood pressure is equal to cardiac output times resistance. If resistance goes down, what happens to the blood pressure? It goes down. And so we can utilize this in patients who have hypertension. It's actually very good. It's one of the first line drugs in essential hypertension. So it's good in hypertension. So that's one of the potential benefits of this drug. So when we talk about this drug, what are we again utilizing it for? The diuretic effect is hypervolemia plus when they have hypernatremia, so it's a combo. But we can also utilize it in hypercalciuric states. So people who have high risk of calcium phosphate stones and oxalate stones, people who have osteoporosis, and we can even utilize it in essential hypertension. The complications that come along with this drug is just the same as it would be with loop diuretics with a couple combos here. So again, one thing is you inhibit uric acid excretion. If you inhibit uric acid excretion, what do you increase the risk of again? You can cause hyperuricemia. And so if you increase the uric acid levels in the serum, you can increase the risk of gout. And so that is a potential risk factor that we talk about. Funny enough, we see that thiazide diuretics have a higher risk of gout than loop diuretics do. And so that's important to remember. The other thing here is because you're blocking sodium reabsorption here, right? So sodium is supposed to be reabsorbed here along with chloride. But if you're blocking that, what you're doing is you're increasing the distal sodium delivery then. So then more sodium is going to be delivered to the distal tubule. Now the problem with that is that you can end up with a lot of sodium loss, right? And with that sodium loss, if I dump a lot of the sodium into my actual urine, one of the things that can happen here is if you get lots and lots of sodium loss and you even get some water loss, you can get two effects here, two primary effects. One is if you lose more sodium than you do water, you increase the risk of hyponatremia. And if you get rid of a lot of sodium in water, you increase the risk of hypovolemia. And so you really want to watch out for this, is that these patients are high risk for hyponatremia and high risk for hypovolemia, all right? Now, the other concept is whenever you deliver lots of sodium to the distal tubule, who is also around that area that loves a lot of sodium? When you got lots of sodium, again, what I say happens? Some can get reabsorbed in the collecting duct. Some can get reabsorbed here in the collecting duct. And when you reabsorb that sodium, who comes popping on out? Again, do you guys remember? The potassium will come out and the protons will come out. And so essentially what will happen is you will dump a lot of potassium into the urine and a lot of protons into the urine. And if I dump these into the urine, so I get an increase in potassium loss and I get an increase in proton loss, right, with both of these guys. Increased potassium loss. What does this increase the risk of? Hypokalemia. So now I have the risk of hypokalemia. And then if I increase proton loss, I increase the risk of metabolic alkalosis. So now, with that being said, you're kind of noticing some similarities here. Patients who can take thiazides can get hypovolemia, they can get hyponatremia. I see hypernatremia being a little bit more common in loop diuretics though, right? We said that. Metabolic alkalosis is similar, hypokalemia is similar. Uric acid, what's different? Oh yeah, that's right. They reabsorb calcium a little bit more. So I actually will stimulate this process more. And so I can increase the calcium in the serum. And so this means that this patient is at higher risk for hypercalcemia. So they can get hypercalcemia. And so these are the big complications that I want to watch out for. I want to make sure that they don't get too hypercalcemic. I want to make sure that they don't get too hypokalemic. I want to make sure they don't get too alkalotic. They don't get too hypovolemic, so in other words, decreased skin turgor, dry mucous membranes, hypotension, AKI. I want to make sure they don't get too hyponatremic as well, and they don't have any features of high risk of gout. The last thing is, when you give a thiazide, especially in these particular scenarios, what could be an adverse effect if you're utilizing it for hypertension? You could drop their blood pressure a little bit too much and you do run the risk of hypotension. So another thing is, there is a slight risk of hypotension if you just kind of maybe escalate the drug a little bit too much. And I'd say the one that has the highest risk of hypotension is going to be your chlorthalidone. So chlorthalidone is a little bit more powerful, and even chlorothiazides are really good hypertensive drugs. So this is going to be the big thing to remember for thiazide diuretics. All right, we come to our last one, the potassium-sparing diuretics. With the potassium-sparing diuretics, the big things you have to remember is, again, we're targeting the distal convoluted tubule, the distal part of it, the late part of it, and the cortical collecting duct. And again, what we remember is the biggest component here is that we are blocking, whether it's the aldosterone antagonists or the ENaC blockers, we're blocking sodium reabsorption. And then we're also blocking potassium and proton excretion. So the two effects here is that this patient, if we're blocking, so you're going to block sodium reabsorption and you're going to block potassium and proton excretion, what's the overall effect? More sodium will get lost. So I'm going to kind of bring this down here like this. You're going to increase sodium loss. And so because of that increased sodium loss, you can utilize this because it will cause a little bit of water loss as well. Just a little bit, nothing insane, but you will get a little bit of water loss. And the benefit of this is that this can be utilized in hypervolemia. So it is good in hypervolemia, but it's only in certain scenarios. And I'd say the best indication for this is it's an add-on therapy. It's an add-on therapy when a patient who's getting diuresed has hypokalemia, persistent hypokalemia. So if your potassium level just persistently remains low and you're having to give a lot of potassium replacement as you're diuresing these patients, this may be a good time to add this drug on. So whenever you have a hypervolemic patient, loop diuretics first. They get hypernatremic, thiazides. They get hypokalemic, I'd probably do a potassium-sparing diuretic. And if they get alkalotic, add on a carbonic anhydrase inhibitor. So that's kind of the mechanism here. But the other concept here is that this drug, the reason why is because you're causing sodium and water loss, but you're blocking potassium excretion. So the big thing, potassium and proton excretion, it's going to lead to an increase in the serum potassium. And that's the concept here of why this is actually one of those good drugs where you could utilize it in a patient with persistent hypokalemia. Now, that's one indication. I'd say other indications of why this drug is utilized is in patients who have high aldosterone states. So hyperaldosteronism. This could be primary. In other words, a patient who has an adrenal tumor pumping out aldosterone, so Conn syndrome, and it can also be secondary, patients who have CHF, renal artery stenosis, etc., or a cirrhosis. But the concept here is that, in the kidneys, if it's releasing a lot of renin, we know renin leads to the formation eventually of angiotensin 1. Angiotensin 1 leads to the formation of angiotensin 2, and then angiotensin 2 increases the production of aldosterone. And then also ADH2, right? But what we know is that whenever there's these high renin states, and we increase this, we increase this, we increase this, we increase this, what are we doing? We're kind of essentially in this process, we're increasing aldosterone because aldosterone wants to really work on the kidneys to increase sodium and water reabsorption. And so because we want to do that to that sodium and water reabsorption, the problem with this sodium and water reabsorption is that this kind of can cause kind of an overloaded state. So it increases edema and it increases a lot of retention, right? So edema and volume overload. So edema and volume overload. This is terrible in a patient who has things like CHF and who has cirrhosis, right? And so in these patients, this is potentially a drug that I would want to give, right? Because now let's watch why. In hyperaldosterone states, I would give the aldosterone antagonists. So only those, not the amiloride, not the triamterene, only spironolactone or eplerenone. So give aldosterone antagonists. And when you give aldosterone antagonists, what these are going to do is these are basically going to, they're going to particularly work to block aldosterone. So these are going to work to block here. And so you're going to end up with decreased aldosterone, right? Because I'm going to block this pathway. When I have decreased aldosterone effect, I'm going to inhibit sodium and water reabsorption. I'm going to decrease edema. I'm going to decrease volume overload, a lot less sodium and water retention essentially. And that is going to be good in CHF and good in cirrhosis. So this is really good in CHF and in cirrhosis. Funny enough, CHF, this has actually been shown to reduce mortality. So we add it on as a drug, for example, if a patient's on an ACE inhibitor or an R plus a beta blocker and they're still having some problems and symptomatic or have a reduced EF, add on an aldosterone antagonist. Or if a patient has cirrhosis, this is actually the best diuretic. You actually give this in a 2.5 to 1 ratio with loop diuretics. So this is a really good diuretic in these particular scenarios. So this is what I would want you to remember, is it's good in these particular scenarios. And also, you can give this in any hyperaldo state. So if a patient has a Conn syndrome, they have an aldosterone secreting tumor from their adrenal cortex, it would also be good there. All right. Now, with that being said, we're giving it the diuretic effect if they have hypokalemia, persistent hypokalemia, because it's going to retain potassium. We can also give it in hyperaldo states, especially CHF, cirrhosis, and even in hyperaldosteronism primary like Conn syndrome. The big complications with this drug is, again, you're thinking about this, is you're not going to reabsorb sodium, you're not going to secrete potassium, and you're not going to secrete protons. So if you think about this, if you don't do these particular things, we'll say that you're blocking this, and you're blocking this, right? So we'll start over here. First thing is you're going to have increase sodium loss. The chances of hypovolemia with this drug are a little bit lower, but it does actually run a slight risk of hyponatremia. So funny enough, you can also see this drug causing hyponatremia. But I'd say the biggest one is the potassium. Because you're blocking potassium excretion, you decrease potassium losses. And if you decrease that potassium loss, you increase the risk of hyperkalemia. And so just be careful of this and keep mindful of this, especially if they have any ECG changes. And lastly, it also decreases proton loss. And if you decrease proton loss, what are you doing? You're retaining protons. What happens to the pH in your serum? It starts to go down. As it starts to go down, what would this be indicative of? Metabolic acidosis. So this patient is at risk of metabolic acidosis. So funny enough, if patients are developing, you're diuresing somebody with loop diuretic for hypervolemia, they develop metabolic alkalosis, you could use this one, especially if they have hypokalemia, or you could use carbonic anhydrase if they have a normal potassium. If their sodium's going up, thiazide diuretic. If their potassium's remaining persistently low, potassium sparing diuretic. That's the concept that I want you to remember. The last complication that we can see, especially with the aldosterone antagonists, so with aldosterone antagonists, you can see gynecomastia. And this is pretty straightforward. Aldosterone is a steroid hormone. And so whenever you give a drug like an aldosterone antagonist, you can potentially block that steroid, and that actually can lead to less testosterone synthesis, less conversion or formation of testosterone, and that can lead to this gynecomastia effect. And you can also increase the conversion of androgens to estrogens. And so all of these things increase the risk of gynecomastia. So with the potassium-sparing diuretics, just again remember, great drug in patients who have hypervolemia as an add-on therapy for hypokalemia, but its more dynamic use is in reducing mortality from hyperaldosterone states in patients with CHF and cirrhosis. And also, biggest complications is hyperkalemia. Also, metabolic acidosis, and then lastly, it can carry the risk of hyponatremia. The risk of hypovolemia is lower with this one. All right. It can even be used in hypertension if a patient has persistent hypokalemia, but it's not a first-line agent. I wouldn't prescribe that as a first-line agent. So with that being said, that's a lot, right? What I want to do now is I want to take you guys through saying, okay, here's my patient who has hypervolemia. How do I really generate a diuretic regimen and know when to keep diuresing them, when to add on another adjunct, when to stop diuresing? Let's go through that now. The last thing that I want to talk about here before we start kind of really getting into understanding how to utilize diuretics is understanding that the most commonly used diuretic that you'll see in patients is going to be loop diuretics. And again, we give these based upon a concept that we have a dose response curve. What the heck does that even mean, Zach? I got you. It's a sigmoidal relationship. And so we start off with this curve here. When we give a diuretic, you'll see over time that it has this kind of peak effect, and you'll see the duration. Oftentimes, usually these drugs last about 6 hours. All right. If we kind of really look at this curve, we can form a sigmoidal relationship off the dose and the response. So we'll see the diuretic dose here, and we'll see the response, which is the ability to secrete sodium and water. What you'll notice here is that there is a certain dosage that we have to give before the patient actually starts making urine. All right. That's usually called the threshold dose. That's the dose that I have to give. Maybe for one patient, it's 20 milligrams. Maybe for another patient, it's 40 milligrams. But I have to figure out what's the threshold that I need to give to cause the patient to urinate. This tends to be different based upon the patient's underlying chronic kidney disease or CHF, etc. Now, what happens is, let's say that you start off at 40 milligrams and you have this diuretic effect. And as you increase the dose, you notice that the natriuresis is increasing and increasing and increasing and increasing. But eventually you hit this point here where we stop seeing kind of an increase in the effect. It kind of plateaus, if you will. So you reach the dose that after this, you get no more benefit, no more extra diuresis. That's our ceiling dose, all right? That's the max dose. Beyond this, you get no additional effect. Maybe this is 40 milligrams. Maybe this is at 120 or 200 milligrams. But if you give this or you give anything beyond that dose, you're not going to get any beneficial effect. So stay in this range and you'll get that maximum diuretic effect, all right? Now, one last thing to think about here is that when we talk about loop diuretics, this is commonly tested, it's important to know that these all have the same efficacy. They just have different levels of potency or dosing. And so we often like to remember this via the 4-2-1 rule, that 40 milligrams of IV furosemide is equal to 20 milligrams of IV torsemide and 1 milligram of IV bumetanide. So if a patient comes in and, okay, I'm going to give them 40 milligrams of furosemide, but the actual attending says, what would that be in bumetanide? Just remember this ratio and you can help for yourself easily to quickly convert that dose. All right. The other thing to remember here, just as a little add-on and a note, is that 40 milligrams of IV furosemide, this is actually going to be really important in the sense that when you actually talk about IV and PO dosing, it actually tends to be you need double the dose for PO to have the same effect as an IV dose. And so remember that the ratio between IV to PO is that for every one of that IV, you would need 2 times that for the PO version. All right, just because the bioavailability, as it gets kind of ingested, absorbed, and metabolized by the liver, you really reduce that and you chew it up, and it only has about 50% bioavailability, which is really important to remember. All right. Let's put everything together now and think about if a patient comes in, they're volume overloaded, how do I know which diuretic to grab for? How do I know what my dose is? How frequent I give? When do I stop? When do I keep going? Etc. So you really have to have a good volume status exam, right? If I look at the patient, they look dry, right? They look like a mummy, right? They got decreased skin turgor, they got dry mucous membranes. I also noticed that they have a very flat jugular vein, their central venous pressure is really low. They have oliguria, they're not making a lot of urine, maybe indicating that they're not perfusing their kidneys very well. This could be concerning that the patient's kind of hypovolemic, right? And if I add on here that they even have a little bit of tachycardia and hypotension, then we're kind of getting more into kind of like the instability portion here. And so this is really concerning that the patient is volume depleted and hypovolemic, and you definitely don't want to give them any more diuretics. And if anything, I might give them a little bit of fluids, all right? If on the other hand, I look at the patient, their jugular vein is gargantuous, right? So their central venous pressure is high. So they're a little bit overloaded in that right heart. I look in their kidneys, they're not making urine, but because their central venous pressure is high, they're congesting the kidney and reducing the blood flow out of the kidney. Their BP maybe is on the higher end. They have pulmonary edema that's evident via maybe crackles on auscultation or rales. Their chest x-ray shows this kind of like bilateral opacities. They have some hypoxia or dyspnea, or they have effusions that are kind of blunting those costophrenic angles. They have peripheral edema, maybe 2+, 3+. Their legs look like they have the Michelin Man going on. They have ascites. I'd say this is less common, especially if the left heart failure, but you can see this if they progress to right heart failure, if they have cirrhosis. But I'd say the biggest thing that I like to look at as an ICU individual is I like to monitor their daily weights. All right, this tends to be a really good way of determining if the patient's a little bit more volume overloaded. So if they weighed themselves 2 days ago and their weight was 110 kilograms, and all of a sudden you weigh them 2 days later and they're 114 kilograms, they've gained weight. And so that's really important to remember, especially in patients who are very fluid retainers, like CKD, CHF, etc. And so weight gain is a really strong indicator that the patient could be volume overloaded. In this potential scenario, they may need a loop diuretic. And so that's the best one that'll give you the best bang for your buck. It'll really help to induce natriuresis. So when I initiate the loop diuretic, I'm giving it for a patient who's hypervolemic. I like to give it if their sodium is kind of in the normal range. I like to keep an eye on their potassium and make sure that that's good as well, right? And I like to watch that bicarb. If I'm doing this and I'm diuresing the patient, I'm getting off some of his fluid, and their volume status still is up, their sodium's fine, their potassium's fine, their bicarb's fine, I don't really need to add on any other diuretics. I can keep on with my loop diuretic, and maybe I just have to keep increasing the dose, right? So start at my threshold, maybe keep going until I get a good diuretic effect. Once I reach kind of that ceiling dose, again, there's not going to be any more benefit to going above that. But one thing I can do is I can increase the frequency. So because we know this drug lasts about 6 hours, I can give a good dose, and then I can give another one 6 hours later, and just keep trying to pull that fluid off. Try to get that weight down. Try to get some of that edema down. Try to improve their pulmonary edema. Try to decrease their jugular venous pressure. Try to improve their urine output and decongest them. And if I'm doing that, great. But if I start to overdo it, and the patient starts to get hypovolemic, right? They get decreased skin turgor, dry mucous membranes. Their JVP goes down. They get a little bit hypotensive, right? They get an acute kidney injury. I've over-diuresed them. I got to stop the diuretics, hold off, see if I can avoid any more diuresis. And if maybe it's too bad, I might have to give them back a little bit of fluid that I took off. Here's where it gets a little bit more complicated. If I do this, I increase my dose, or I give it more frequently, and I'm still pulling off fluid, but I got to keep pulling off more. So they're still hypervolemic, but the sodium's trending up. What's the drug that helps to get rid of sodium? Thiazides. What's the things that you want to watch out for with thiazide diuretics, though? You want to watch out for what? Hypokalemia, metabolic alkalosis. You also want to watch out for hypercalcemia, and you also want to watch out for hypokalemia, and again, the increased risk of gout as well, right? If the patient's hypervolemic, and I notice the potassium's down. Oh, that's the potassium sparing diuretic, baby. I get that one, and it'll help to bring the potassium up, right? So that's a benefit to this drug. I'll add that one on. What's the things to watch out for, though, with this one? It can cause a little bit of hyponatremia, right? It's not going to be as bad as a thiazide, though. It can cause hyperkalemia, though. Be careful and watch out for that. What else did we say, though? I want to watch out for those protons, because what can it do to the protons? It can cause metabolic acidosis, because it can actually help to block the proton excretion, so you can build up protons in the blood. If the patient's hypervolemic and they're having an increase in their bicarb, they're getting very alkalotic, what drug could I give? I could give this one, but what's another one that I talked about that really helps to get you to lose bicarb? Your acetazolamide, your carbonic anhydrase inhibitor. So this is the way that I want you to try to analyze the necessity of adding on diuretics as needed, instead of just continuing to use a loop diuretic on its own. My friends, this was an awesome lecture. I really hope that it made sense. I hope that you guys enjoyed it. Love you, thank you, and as always, until next time.